So as has been brought up, I was asked to prepare a presentation on what is the right time for transplantation. And I assume this came out of some of the content from ASH this year. So next slide, please. So just to kind of frame it, let's say we have a 45-year-old male with no significant past medical history who has unexpected fatigue while on a ski trip. His fatigue increases on his return home. His laboratory studies reveal pancytopenia. His marrow reveals a diagnosis of AML, which is FLT3 wild type, ITD, FLT3 wild type, unmutated. He was induced with daunorubicin and cytarabine. HLA typing done on admission and a donor search was initiated. His day 14 marrow was ablated. He has a delay in count recovery, and a repeat marrow at that time shows 9% blasts. Next, please. So he has primary refractory AML. The options are to proceed to allogeneic transplant immediately or salvage chemotherapy to attempt to achieve remission, then proceed to transplant. Next, please. And I say that based on the presentation from ASH of 2022, which was presented by the Study Alliance Leukemia, looking at in patients with relapsed refractory AML, sequential conditioning and immediate allotransplant resulted in similar overall survival in leukemia-free survival compared to intensive remission induction followed by allotransplant. It was results from a randomized phase 3 ASAP trial. Next, please. So the design of the trial was this. The hypothesis was that salvage chemotherapy would not provide a net benefit. They took patients between the ages of 18 and 75 who had a poor response after first induction or had first untreated relapse and had an HLA-compatible donor and were fit for salvage and transplant. Those who got reinduction received salvage therapy with a high-dose Ara-C-based regimen with mitoxantrone, and then their conditioning intensity was based on the residual AML at the time of reassessment. And those randomized to disease control either just got watchful waiting or were allowed to get low-dose cytarabine or low-dose mitoxantrone. And then they got sequential conditioning, FLAMSA reduced intensity followed by high-dose melphalan and flu TBI. Next, and the primary endpoint was disease-free survival at day 56. And they also looked at overall survival from randomization. Next. So this is the patient flow. If you look at the disease control arm, so the majority of those patients got watchful waiting, a few got mitoxantrone alone, some got low-dose Ara-C and mitoxantrone, some got low-dose Ara-C alone. Almost all went to transplant. 76% were bridged to transplant by watchful waiting. A few, one I think got salvage therapy and transplant, despite the fact that they were randomized to disease control. And then the majority of the patients, as you can see, were in complete remission after transplant. A few were not in remission after transplant. A few had early deaths after transplant. And there were a couple that did not go to transplant. If you look at the remission induction arm, the reinduction arm, almost all got salvage therapy. A few did not. One went to transplant without salvage therapy. One died and one dropped out without transplant. About half of those patients achieved a complete remission prior to transplant. Half did not achieve a remission prior to transplant. And regardless of that, they all went to transplant. The majority of those patients achieved remission after transplant, whether they were not or were in remission at the time of transplant. The median time to transplant was 8 weeks, and at 24 weeks, 96% had undergone transplant. In the disease control arm, the median time to transplant was 4 weeks, and at 24 weeks, 98% had undergone transplant. Next. So looking at the primary endpoint, disease-free survival at day 56, it was 84% in the disease control arm and 81% in the reinduction arm, so no significant difference, and no significant difference at overall survival with a median follow-up of 37 months. Next. As might be expected, there were fewer grade 3 or greater AEs and less time in the hospital with the disease control arm. But other than that, there was no significant difference in terms of day 28 mortality, in terms of the reasons that they did not go to transplant, in terms of the likelihood of VOD, in terms of whether or not they were discharged from the hospital within 28 days of transplant, and in terms of in-hospital deaths before day 56. Next. So the interpretation, the conclusions from this ASAP trial is that there was no beneficial effect of salvage chemotherapy based on high-dose cytarabine plus anthracycline prior to transplant for patients with poor response after first induction therapy or relapsed AML, that watchful waiting and sequential conditioning prior to transplant resulted in comparable CR rates and overall survival and may be the preferred option whenever a stem cell donor is readily available, that patients spent less time in the hospital with disease control instead of remission induction, that the impact of morphological CR at the time of transplant seemed less important than expected, that MRD negativity was not required for a good long-term outcome, and that the benefit of any treatment aiming at better long-term outcomes after transplant by inducing a CR prior to transplant should be demonstrated in prospective trials for this patient population. Next, please. But 50% of patients in the treatment arm were not in remission at the time of transplant. Were any patients who received supportive care or low-dose therapy in remission? We don't know. They may have been. And we don't know whether or not there was any impact of disease characteristics. Is this more valid for certain disease types than others? Next, please. So in the same meeting, we had a presentation by the group in the UK showing that high sensitivity detection of FLT3 ITD measurable residual disease by deep sequencing impacts outcome in AML. Next, please. They looked at MRD at pre-allo transplant as a predictor of post-transplant relapse. Next. And they wanted to see the prognostic value and refine the prognosis of co-mutant NPM1 at diagnosis. Next. They had 78 patients who underwent first transplant in remission, and they did NGS on 69 marrows and 9 peripheral blood samples with a very sensitivity of 0.01%. Next. Pre-transplant, there was not significant difference between those who were MRD negative or MRD positive in terms of other factors of disease and transplant. Next. But as you can see, if you look at FLT3 MRD status and those who were in remission versus those who were relapsed at the time of assessment, the remission group had much more, or those who were not detectable were much more likely to be in remission than relapsed. Next. If you look at post-transplant outcome, again, those who are MRD negative prior to transplant were much less likely to relapse. There was a cumulative risk of relapse after transplant was much higher in patients who were NGS MRD positive pre-transplant. Next. And there was an improved relapse-free and overall survival in those who were NGS MRD negative for FLT3 ITD. Next. And they also looked at pre-transplant NPM1, and similarly, those who were NPM1 negative did better than those who were NPM1 positive. Next. So pre-transplant detection of FLT3 detected residual disease and improved post-transplant prognosis and could identify patients who might benefit from an attempt to reduce relapse risk by MRD-directed therapy, although that was not shown. Next. And this follows on data from 6 months earlier in the pre-measure study that was presented by Chris Hurrigan at the NIH, where they looked at adult patients with non-APL AML and CR1 who underwent first allo transplant between 2013 and 2017 and had bank blood samples. Next. They looked at impact of MRD on leukemia-free survival with several different mutations. And as you can see here, there was previous data that suggested that MRD negative patients did better than MRD positive patients. Next. And here they looked at NGS MRD pre-allo transplant in AML and CR1 and similarly showed that relapse was higher if you were MRD positive. Relapse-free survival was better if you were MRD negative, as was overall survival. Next. Detection of residual FLT3 ITD was prognostic. Those who were MRD positive did worse if they still had evidence of the FLT3 ITD than those who did not. Next. Same was true for NPM1. Next. but it was not true for IDH. Residual IDH was not associated with relapse risk. Next. Conditioning intensity did have an impact on those who were NPM1 mutated, but did not have an impact on those who were FLT3 mutated. They did poorly regardless of conditioning intensity. Next. So this brings up the question of when to transplant patients with AML. We know that the indications are higher intermediate disease in CR1, primary refractory disease, or relapse disease. There's data that patients with FLT3 ITD and NPM1 mutated disease who have persistent MRD at transplant have worse outcome than those who are MRD negative. A randomized trial of salvage therapy versus immediate transplant did not demonstrate a benefit to transplant. So it brings us these questions. Do any patients really benefit from salvage therapy? Or does additional therapy to eradicate MRD improve outcome? Or is it the disease biology of those who become MRD negative that allow them to do better even if they don't get salvage therapy? And how does this allow us to determine when we should be transplanting these patients? Next. I'm going to open it up for discussion.
It's a nice presentation, Selina.
Thank you.
Coming back to the first publication that you discussed, presented at ASH 2022 by Steltjes, I still find this a rather strange
Finding.
Yeah, because they say we do not transplant immediately. We do watchful waiting. But if you look to the median time to transplant, it's only 4 weeks. So that's very short for watchful waiting. I should.
Yes.
And also their experimental arm also includes intensive salvage. It's the Flamza regimen. The only difference is that it is immediately followed by an allogeneic stem cell transplantation that also receives conditioning. So it's a rather strange situation. And I agree with you that that the NCS MRD for the FLT3 ITD is very, very prognostic for outcome after transplant. There are now, I think, 3 important publications that show the same, that when you are MRD positive before transplantation, then the outcome is very worse. That does not say that you will that you should not transplant those patients, because you really do not have an alternative.
Right, because you also don't know if salvage therapy to turn them negative will improve their outcome.
Yeah.
And you also don't know whether giving them therapy after transplant will help. And so I think those are things that, you know, if you give them too much salvage, they may lose their opportunity to become transplant candidates.
Yeah, that's a possibility. And well, you did not discuss the possibility post-transplant.
Correct.
Because they are also very encouraging, I should say, and the possibilities are either an early DLI or maintenance treatment with a targeted agent. So there are many possibilities currently. Another possibility, and that's a strategy we use in Hoven, is that we do not transplant in the intermediate risk population MRD negative patients up front, but we give them an autologous stem cell transplantation. And very recently we have shown that we could avoid an allogeneic stem cell transplantation in quite a number of patients. I still think that is an advantage to avoid an allogeneic stem cell transplantation. It was very recently published in Blood.
I agree with all of those points.
Hi, Selina.
Hi, Jeff.
Great job. Really nice
Thank
overview.
you.
Complex topic, to say the least. One thing that wasn't clear to me from the ASAP trial, maybe I just missed it, was prior to being defined as having relapse or refractory disease after induction, what types of initial therapy patients had received. And I guess my point for consideration was that various groups use different intensity of initial therapy that may, I guess, be considered more comprehensive if you use a high-dose Ara-C containing regimen up front as opposed to just a traditional 7+3.
I don't think they did. I think there was a traditional 7+3, but it wasn't only that. If you go back to the eligibility, if you can you go back to like slide 2 or so? They also took patients who were in first relapse. So it was like, I think it was all comers who had low level or had residual disease at the time of being considered for randomization. I don't think it was, I think it was agnostic to what their prior therapy was.
Okay, yeah, I guess I was not clear about what the initial how initial.
Yeah, I don't think they required a particular initial therapy. Yeah. It was because it was first relapse, primary refractory, and positive day 14s, I think. I think they allowed all of those to go on. And
Yeah,
some of
right.
yeah.
So my point was that if the population was enriched for or had a high concentration of day 14 positivity or
Correct.
post-induction, that it's conceivable that if those patients had gotten high-dose cytarabine or a stronger regimen, that
Yeah.
the likelihood of a reinduction would be less
Correct.
successful, and therefore,
Yeah, this was only prospective from the time of randomization. So they kind of took an all-comers group. So you're right, it was not a necessarily equivalent pair.
So what did you do with this patient that you presented first, Selina? Because I'm asking because he was IDH1 positive.
This patient actually went on to transplant.
Immediately?
No, got salvage therapy, went into a remission, and then went to transplant.
Yeah. Did you consider to make use of ivosidenib or not?
This patient did not get.
Oh, sorry.
Yeah, it was no, you were right. It's IDH1 mutated, not ITD1 mutated. The patient was IDH1 mutated. FLT3 wild type, IDH1 mutated. They actually got ivosidenib together with their salvage therapy.
Okay, yeah.
And then they went on to a transplant in first remission.
Dr. Luger, this is Yasushi from Japan.
Yeah.
When we discuss about the relapse refractory, it is clear that they are MRD positive, of course.
Correct. They're more than MRD positive.
Right.
They're correct.
So the first clinical trial dealt with patients who are resistant and they had certain amount of leukemia burden.
Correct. Can you go to the next slide? Next. Yeah.
Then after the following studies you showed dealt with the patient who are clinically or morphologically in remission.
Correct.
And having MLD or not. So the target patients are a little bit different or much different. So in first trial, they had much more resistant patient.
Correct. Yet despite that.
Actually the long-term overall survival after transplantation is very poor. Not I shouldn't say poor, but lower compared to the other two.
Mm-hmm.
So probably we need to differentiate those patient situations to discuss.
Correct. Although some have argued that MRD positivity does just as poorly as morphologic positivity.
Right, but we of course clinically we know that morphological non-CL patient usually show worse prognosis than morphological CL patients.
Right.
So we may have different grade. MLD negative morphological CL, MLD positive morphological CL, and non-CL. So they should have a different prognosis after transplant.
Point well taken.
Hi, So it's Eduardo from Brazil. So first of all, thank you for excellent presentation.
Thank you.
I was wondering if looking for the small letters on the bottom of eligibility, patients with more than 5,000 leukocytes at diagnosis, they were excluded. So I was wondering if this was after some kind of site reduction, or if you have any information on that, because of course maybe we excluded some FLT3 ITDs, for example, in this with this criteria.
Yeah, so it just says patients who had a white count of greater than 50,000 were excluded. If you go to the next, I think there is something about the patient comparison. Is there one there? There may not have been. No. Yes, patients who had a white count greater than 50,000 at presentation were excluded. Go back. And I think that's because there was a concern that they could not be placed on watchful waiting, because if they relapsed in a short period of time with a high white count again, it would not have been safe to just do watchful waiting. So those who had greater than 50,000 were not excluded in this, were not included in this study. So you're right. There may have been a lower rate of FLT3 mutated patients in this trial for that reason.
I mean, I think that one of the important messages that was conveyed by you, and I forget who else just spoke, but the the timing of the transplant is obviously of major consideration, and it raises the question as to how rapidly we can arrange for transplant to be done.
Yeah.
And in the real world setting, most of us do not experience the ability to be able to transplant somebody within
4 weeks.
a month of their initial therapy or their time of whatever disease assessment, response assessment. So I think that's going to be a barrier to accepting these data and being able to really put it into action unless we make a concerted effort to really begin to hammer home the importance of getting transplant up and ready to go as soon as possible. Patients can't wait 12, 16 weeks with no AMC because they're going to deal with some refractory infection. So that I think that's really going to be.
And I mean, that speaks, Jeff, a little bit to the S1203 trial that we did, right? Which looked at getting the NMDP involved from day one and getting patients typed at the time of diagnosis. And that showed that if you type them at the time of diagnosis, you increase the transplant rate in high-risk patients from about 40% to 60%, just because you have that available and these patients don't fall off before they have the opportunity to get transplanted. So I think that that's exactly what you were saying, right? They were only eligible if they had a donor identified at that point and could get to transplant within 4 weeks.
Right.
So, right, you're right. There aren't a lot of patients that fall into that category at this point.
But this is a German study, and it's a policy from Germany to do that. So they have the patient typed at diagnosis. Yeah.
Dr. Luger, in that sense, in Japan, about 30% of allogeneic transplant, we use cord blood. So we need a shorter time period for the arrangement if we use cord blood. But
and will you do that in refractory disease?
Sometimes, yes, but we prefer to do that in complete remission situation.
Yeah.
But I think, Selina, I mean, I think that maybe as many uncertainties exist around this ASAP trial. I mean, the one thing that the trial showed is that you can transplant people that have significant disease burdens with a less than myeloablative transplant. I think many centers don't do that in these days because they just say it doesn't work. So I think that's one of the maybe takeaway messages, even if we don't understand all the other details, that you actually can transplant people, and some of them will be long-term survivors with this, which I thought that's different from what many centers do in these days as far as eligibility for transplant.
Well, they all got the Flamza followed by high-dose melphalan.
Right, but still the same idea. I mean, that you even attempt a transplant with whatever conditioning therapy you pick. I
Right.
mean, I think many centers don't transplant people with quote unquote active leukemia with a
Correct.
less than myeloablative conditioning, whether you use Flamsa beforehand or not.
Yeah.
Which I think is sort of, to me, that's the study that proved that maybe that's not the right thing to do. Maybe you can actually really do this. Maybe what you said before, right? Maybe the difference between morphologic disease and MRD positive remission disease isn't all that different when it comes to post-transplant outcomes. Yes, we withdraw this very arbitrary line who gets a transplant or is eligible for a transplant or not based on how many blasts we see.
Yeah. But I think also in respect to what Jeff said, I think the randomization has to happen up front, right? We need to actually take these patients and have them all start, really get a better sense of what they're getting up front. And are we really dealing with same populations? We can't answer that question here and try and answer that question.
Well, yeah, and I mean, one of the big deficiencies of the trial is that they weren't able to break down quite yet who had a chemotherapy response before transplant, right? It's just sort of the average outcome was not different. But as you said before, I think correctly, that may not be true for subsets. And depending on how many people actually really responded to chemotherapy, you may not capture this by just looking crudely across everybody enrolled on the trial.
But it does bring up the question we all worry about, which is, are we just going to get patients, by giving them salvage, are we going to make them worse transplant candidates rather than better? We don't know that answer. Like when are we giving them too much?
Yeah, I mean, intuitively, you might think we do, right? I mean, if you have a patient with leukemia that you unsuccessfully give salvage chemotherapy to, all you do is you prolong the time of bad blood counts and the chance of running into infectious disease problems. So presumably you didn't help.
Right.
The problem is we're really not good at picking out who we can successfully salvage, right? I mean, all our predictions, they work great for, well, not sure they work great, but they work for larger groups of people on average, but they really don't work well for individual people.
Yeah.
Right. I think that's one of the issues.
Selina, great talk.
Thank
Jorge.
you.
I'm Jorge from Barcelona. I think that the amount of data we have regarding that MRD positivity before transplant is bad, is really very large and very consistent. And I am not sure that this type of trial in which this was not observed is good. On one hand, one of the arms, all patients had MRD and not only MRD. And on the other hand, at least in the abstract, we don't know what was the proportion of patients in the rescue arm that got MRD negativity.
Correct.
And also, is not a very large study. I mean, there are not many patients in the trial. So I would take the conclusion on MRD from this trial with a lot of caution. Another aspect is how to improve these results in MRD positive. Should we do something before transplant, or should we do something after transplant, or should we do both? And probably I agree with Roland Walter that condition intensity may be important. There are several studies showing that it could not be a good idea to give a reduced intensity conditionings for patients who go to transplant and are MRD positive.
I agree. We have several studies now that show that those who are MRD positive do better with myeloablative conditioning. Thank you, everybody.